3. Yeah, like.
Good afternoon, everyone. Myself, Dr. Shweta Sonwalkar, Clinical Head and Fertility Specialist at Oasis Fertility, Belagavi. So today I am discussing regarding evaluation of infertile couple. So when you call the couples as infertile, that is inability of a couple to conceive after more than 12 months of regular intercourse without the use of contraception in women with less than 35 years of age. If the same more than 35 years of age couples, if they try for more than 6 months with regular intercourse without use of contraception, then also we call it as infertile couple. So what is primary infertility then? Then it applies to a couples who have never conceived, and secondary infertility implies that the couples have had an at least a prior pregnancy irrespective of the outcome. So it's affecting 1/5 to 1/6 of a couples in the reproductive age. Approximately 85 to 90% of healthy young couples they conceive within 1 year or within 6 months of their marriage. But infertility it affects approximately 10 to 15% of couples, and therefore it is an important part for the clinical practice. From the beginning, the evaluation of the infertility should focus on the couples and not on one or other partner, regardless of past reproductive performance. So, successful reproduction requires proper structure and function of entire reproductive axis, including hypothalamus, pituitary gland, ovaries, fallopian tubes, uterus, cervix, and vagina. So, causes of infertility, most of the 40% of the causes are because of the ovulatory dysfunction, and another 40% tubal and pelvic pathology is present, and another 10% is by unexplained infertility, and unusual problems accounts for another 10% of cause for infertility. So when we should start evaluating a couple, that is treatment may be initiated at 12 months if the patient is less than 35 years of age. But if the patient is more than 35 years of age, the treatment and evaluation should start at 6 months. And if the female patient is more than 40 years of the age, the evaluation should start immediately. And diagnostic testing for infertility should be initiated without delay on presentation with the conditions such as if the woman is having irregular menstrual cycles, length of less than 25 days, then intermenstrual bleeding, oligomenorrhea or amenorrhea, or if the patient is known or suspected any uterine or tubal pathologies or peritoneal disease or endometriosis, and known or suspected male subfertility and sexual dysfunction, and if any genetic or acquired conditions which predispose to diminished ovarian reserve, for example chemotherapy, radiation exposure. So we have to start evaluating them immediately. Then what are the tests which are required for female infertility? Are tests for we have to take a history of the patient and do a physical examination, and test for ovulation, test for ovarian reserve, any uterine pathologies, test for tubal factor evaluation, then pelvic factors and additional workup should be done. Whereas in case of male infertility, complete history and physical examination of a person is needed, and complete semen analysis should be done, and endocrine evaluation and additional special workup in some selected patients. So ovulatory dysfunction, which accounts for 40% of the infertile couple. So causes for these ovulatory dysfunctions mainly includes PCOS, that is polycystic ovarian syndrome, obese patients, perimenopausal patients, patients who have weight gain or weight loss or strenuous and excessive exercise, thyroid dysfunction, and hyperprolactinemia. These conditions cause ovulatory dysfunction. So we have to exclude the pregnancy in ovulatory dysfunction patients. Um, then menstrual history by asking the history of oligomenorrhea, amenorrhea. It is clinically sufficient to establish the anovulation history. And in selected patient, luteal progesterone is done to confirm the ovulation, and timing of this test is 1 week before the expected menses, that is on day 21 of the menstrual cycle, and the progesterone concentration of more than 3 nanogram per ml determines ovulation according to NICE criteria. Then ovulation predictor kits are available in the market, and it prece- mid-cycle LH surge that precedes ovulation within 1 to 2 days. It is an indirect evidence of ovulation. And in cases of PCOS patients, they have got a tonic elevation in basal LH levels, so leading to false positive results with these urinary LH level kits. And another test like basal body temperature, it is not routinely used now, and endometrial biopsy also no longer recommended, and it is to be done in patients with endometrial pathologies like hyperplasia, neoplasia, or endometritis. uh, then diagnosis of and treatment of luteal phase deficiency. Clinically, LPD, it refers to luteal phase of less than 10 days in length, but alternate definitions include less than 11 days and less than 9 days. If the maturation of the endometrium is delayed by inadequate ovarian hormone secretion, or whether it is delayed because of an intrinsic endometrial abnormality, the resulting defect prevents normal implantation. So studies that have defined the diagnostic criteria for LPD using endometrial biopsy have relied on the traditional microscopic appearance of luteal phase endometrial development. Then transvaginal ultrasonography is done to assess the ovarian reserve, that is size and number of small antral follicles and developing follicles, and to identify the adnexal or uterine and endometrial pathologies, progressive follicular growth of growth, that is follicular monitoring. Then it provides presumptive evidence of ovulation, that is loss of clear margins of the follicle, sudden collapse of the follicle, fluid in the pouch of Douglas, and luteinization. So these all we can see by transvaginal ultrasonography. Then hormonal testing is done like TSH to confirm any thyroid disorders, then prolactin, high FSH, and low estrogen levels on day 2 of the cycle. If it is in, then it is suggestive of ovarian insufficiency. In such cases, the patient may need oocyte donation program, and if the FSH is low or normal with low estrogen on day 2 of the menses, then that suggests hypogonadotropic hypogonadism. So for such patients, they need exogenous gonadotrophin stimulation for ovulation induction treatment. And test for ovarian reserve is done by doing anti-Mullerian hormone testing. Then, if any signs of androgen excess are present, then we have to do 17 hydroxyprogesterone, serum testosterone levels, DHEAS, and androstenedione. So markers of ovarian reserves are day 2 or day 3 FSH and E2, AMH, and AFC. These are the main tests which are recommended. And upper threshold of FSH should be 8.9 to 25, and AMH more than 3.5 nanogram per ml shows high ovarian response patients, and if it is less than 0.75 nanogram per ml, then the patients are of low response to the treatment. Then AFC, antral follicle count, if they are more than 16, so that predicts high response to ovarian stimulation treatment. And if it is less than 4 follicles, then low response to the ovarian stimulation. Then cervical factors which affects which accounts for infertility are like stenosis of the cervix or chronic cervicitis. We have to evaluate such patients. Then clinical history of previous any cervical surgical procedures or abnormal discharge should be addressed and treated. Abnormalities of cervical mucus production or sperm mucus interactions, they are rarely the sole of principal cause of infertility. And the postcoital test, it is no longer recommended nowadays. Then uterine abnormalities like polyps, submucous fibroids, which accounts for 2.8% of the cases, and adhesions. These are the very common abnormalities of the uterus. So ultrasonography is the best imaging modality in such cases, which are available to assess this uterine anatomy. Then transvaginal ultrasound is done to rule out uterine pathologies such as leiomyomas, that is fibroids, endometrial polyps, adenomyosis, and congenital uterine anomalies. So, which may play a role in case of infertility. So 3D ultrasonography is done to rule out uterine pathologies, but its limitations are less diagnostic value in differentiating submucosal fibroids in presence of multiple fibroids and endometrial polyps within a thick endometrium and synechiae or uterine malformations. So one more method, that is hysterosalpingography, is also done to define the size and shape of the uterine cavity. Then any developmental abnormalities like unicornuate uterus, bicornuate uterus, septate uterus, and acquired abnormalities like polyp, submucous myoma, synechiae are ruled out by HST. Its sensitivity is 50% and positive predictive value of 30%. Then saline infusion sonography. It is better defines the size and shape of the uterine cavity, and it has got a high positive predictive value of more than 90% in case of detecting endometrial polyp, submucous myoma, and synechiae. Its sensitivity is 78 to 100% and specificity of 71 to 91% for detecting intrauterine lesions. 3D ultrasonography, when performed, is comparable to hysteroscopy for intrauterine lesions. Next is a hysteroscopy. We call it as a gold standard method. It is a definitive method for diagnosis and treatment of intrauterine pathology. However, cost factors makes it the second option after saline infusion sonography for evaluating the cavity. Then laparoscopy is best for identification of uterine anomalies, any abnormality in the outer counter of the uterus, which is not identified by HSG. Example, bicornuate uterus, endometriosis, then PID causing any adhesions, fibroids, then PCOS can be diagnosed through laparoscopy. Advantage of doing laparoscopy is even treatment can be done in the same setting. Then tubal factors can be assessed with the use of hysterosalpingography. HSG reveals tubal architectural proximal or distal tubal occlusion, then any demonstrating salpingitis isthmus, isthmica nodosa, then febrile phimosis or peritubal adhesions. When the escape of contrast is delayed or when it becomes loculated. So HSG has got a sensitivity of 65% and specificity of 83%. Then hysteroscopic assessment of tubal patency. It is an emerging approach that is performed through the direct observation of fluid or air bubble flow in the tubal ostia. Even its sensitivity is 88% and specificity of 85%. Then laparoscopy is the gold standard but not recommended as a routine method for assessing the tubal patency. The procedure is also can also identified and be used to correct the any tubal factors such as fimbrial phimosis or peritubal adhesions. Then laparoscopy is indicated. Then any peritoneal factors like endometriosis and any pelvic or adnexal lesions may cause a contributory factor to the infertility. So, history or any physical examination findings like history of severe dysmenorrhea, then menorrhagia, they may raise suspicion and peritoneal factors also contribute to unexplained infertility. So, laparoscopy is the only method available for specific diagnosis of peritoneal factors that may impair the fertility. Most of the women with significant adnexal lesions, they have historical risk factors like pelvic pain, moderate or severe endometriosis, pelvic previous any pelvic infection or surgery, or any abnormal HSG findings. But laparoscopy is not recommended for the routine evaluation without a specific suspected pelvic pathology or another specific indications. Now, evaluation of male partner. Uh, even the in the male sperm production, it involves normal functioning of the hypothalamo-pituitary gonadal axis and normal testicular and accessory glands and absence of genetic defects. So, what are the causes for male factor infertility? They may be divided into pre-testicular, testicular, or post-testicular causes, and the percentage of these for that is varicocele accounts for 42.2%, which is highest, and idiopathic is 22.7%. What are the lifestyle factors like obesity, smoking, and alcohol consumption? Then laptop use, taking hot tubs and sauna baths, then wearing a tight underwear, exposure to toxins and heavy metals, use of cell phones, then use of drug and steroid misuse. All these they account for decreased in the sperm count and motility. There are many factors which are that is hypothalamic pituitary disorders, many causes which comes under this disorder, and primary gonadal disorders and disorders of sperm transport. Those all accounts for causes for male infertility. So, how to evaluate this male infertility? Infertile male is taking a history and examination and investigating a male person. Like history involves fertility history, like duration of marriage, uh, then past any conception with present or previous partner, then any previous fertility investigation and treatments already done. Then sexual history should be elicited like frequency of intercourse, loss of libido, erectile function, or ejaculation, any lubrication usage during intercourse. Then, if the patient is having any medical conditions like diabetes, hypertension, respiratory tract disease, neurological disease, high fever, then urinary tract infection, which all these contribute to uh, loss of uh, semen volume or sperm dysfunction. Then, if the patient has any history of vasectomy, testicular surgeries, any inguinal hernia, then prostatectomy, bladder neck operations has to be elicited. Then, developmental or childhood history like mumps or any other viral illness in case when the patient was uh, like any childhood history, testicular torsion, then puberty and its onset, sexual development of the person, any occupational exposure to heat, toxins, carcinogenic dyes, or tannins, etc., any substance abuse has to be elicited. Then examination, which includes scrotal examination, like size and consistency of the testis, palpable vas difference, then presence of any or grade of varicocele has to be checked. Then abdominal examination are done for the presence of any scars in the inguinal hernia, inguinal area, in cases of inguinal surgeries or treatment for any undescended testis. Then patient is asked for any investigations like many semen analysis, then endocrine evaluations such as FSH, serum testosterone, LH and estrogen, prolactin, TSH. Then genetic testing is recommended in selected patients like karyotyping, Y microdeletions, CFTR gene mutation studies. Then, according to WHO 2021, the normal semen parameter should be semen volume of 1.4 ml, then with a total sperm count of 39 millions, then total motility of 42%, and vitality of 54%, and 4% of normal morphological sperms. There are some abnormalities of the sperms like aspermia means absence of semen, azoospermia means absence of sperm in the semen, hypospermia means low semen volume, hyperspermia that is high semen volume, oligozoospermia very low sperm count, polyzoospermia means abnormally high sperm count in the ejaculate. Asthenozoospermia means poor sperm motility. Teratozoospermia means sperms that have morphological defects. Then necrozoospermia, all the sperms in the ejaculate are dead. Leucospermia means high level of white blood cells present in the semen. So after semen analysis, we have to conclude the semen parameters. If indicated, then endocrine evaluation in the infertile men includes abnormal semen analysis, particularly sperm concentration of less than 10 millions per ml. Then, if the patient has any sexual dysfunctions like decreased libido, impotence, and other clinical symptoms or findings that suggest a specific endocrinopathy, then endocrine evaluation should be done. The hormonal profiles such as increase in the FSH, LH, and decrease in the testosterone levels if present is suggestive of testicular failure. If the FSH is high, LH is normal, and even testosterone is normal, then that suggests failure of spermatogenesis. And decrease in the FSH, decrease in the LH, and testosterone that suggests hypogonadotropic hypogonadism. So, in such cases, genetic evaluations like karyotype, Y chromosome microdeletion, CFTR gene mutation, and DNA fragmentation index should be done. And indications of genetic testing in the males include men with infertility of unknown etiology and sperm concentration of less than 10 millions per ml who are candidates for assisted reproductive technology. In them, we recommend Y chromosome microdeletion and G band karyotyping. And non-obstructive azoospermia in a male considering testicular sperm retrieval of ART. For them also, Y chromosome microdeletion and G band karyotyping is recommended. Azoospermic or oligospermic men with absence of at least one vast difference at physical examination, if it is seen, then CFTR gene mutation analysis is carried out. And also in cases of azoospermic men with signs of normal spermatogenesis, example obstructive azoospermia of unknown origin. For them also CFTR gene mutation analysis is carried out. Then history of any recurrent miscarriage or person or family history of genetic syndrome is present, then gene and karyotyping is suggested. American Neurology Society Committee has opined for couples with RPL, men should be evaluated with karyotype and sperm DNA fragmentation. Then karyotype and Y chromosome microdeletion analysis should be recommended for men with primary infertility and azoospermia or severe oligozoospermia, that is less than 5 million sperms per ml, with elevated FSH and testicular biopsy, or a presumed diagnosis of impaired sperm production as the cause for azoospermia. And other tests like scrotal ultrasonography for testicular volume, then transrectal ultrasonography, testicular biopsy, only if the place has the facility of sperm cryopreservation, then patient has to advised testicular biopsy. A trial TISA may be carried out in the place of biopsy, followed by cryopreservation of any sperm retrieved. Then transabdominal ultrasound is done to rule out any renal agenesis, like unilateral kidneys, which accounts for 10 to 15% of CBAVD. Therefore, counseling of the infertile couple becomes very important. In many couples, the inability to conceive results in feelings that they have lost control over an important and very personal part of their lives. So, the process of evaluation and associated uncertainty significantly adds to their the burden. So, infertile couples often need the opportunity to express their concerns, frustrations, and fears, and support the groups can help to meet that need. Counseling must be an ongoing process during both evaluation and treatment. So, regular visits to review and critic results and to outline the recommendations for further evaluation and treatment helps to ensure that all the couple's medical, emotional, and financial needs and concerns are addressed effectively in a timely fashion. And treatment for male infertility in case of mild to moderate diseases, intrauterine insemination is recommended. And in case of severe diseases, a person can go for intracytoplasmic sperm injection, that is ICSI, and IVF. Uh, like indicated in a person like poor semen analysis, fertilization failure with standard IVF. Then other treatments like surgical reanastomosis, FSH replacement, or JNRH, then donor sperm insemination. Thank you. I am free to answer any questions. How do you determine the egg quality in a female? Egg quality in a female, the very can be identified by the age of a female person. If once the patient, female patient, crosses 30 years of age, her egg starts, quality of the egg starts coming down. And if she crosses more than 35, the percentage of even conception because of the poor quality oocytes starts increasing. So age is the main criteria for quality of the eggs. When are genetic tests recommended for male infertility evaluation? As I told, if genetic testing are recommended in cases of azoospermia, that is non-obstructive azoospermia, and very severe oligoasthenoteratozoospermia. If and other cases like if already any genetic abnormalities are present in the family history. So genetic tests are recommended. How do you assess for potential genetic or chromosomal abnormalities that may affect female infertility? So, genetic and chromosomal abnormalities mainly affects the female. Once they cross the age of 30 years, the chances of um, Down's babies are more. And if the age is more than, if they cross more than 35 years of age, it aneuploidy chances are increased. So in such cases, age is the main criteria, and even the family history of any genetic disorders in such patients also genetic testing is recommended, like PGTA, PGTM, and PGTSR. Thank you.